HEIDE's partner HEIDE's partnering with the Medical Society of Delaware to present the Working for Equity lecture series over the next year. The Medical Society has kindly agreed to host this as part of their Hot Topic CME series. The Hot Topic CME series was established in 2015 by past president Dr. Stephen Kushner and provides up-to-date and targeted education on emerging medical topics important to healthcare in Delaware. This program enables clinicians to keep abreast of crucial medical information, enhance their skills, and fulfill state licensing requirements. The inclusion of the Working for Equity series underscores the Medical Society's dedication to offering relevant and progressive education for medical professionals in Delaware. The Working for Equity series will bring you current medical information with a health equity focus. And now it is my privilege to introduce our guest lecturer, Dr. Andre Jones. She's a licensed psychologist and professor in the Department of Obstetrics and Gynecology at the University of North Carolina, Chapel Hill. Dr. Jones is also a special expert at the U.S. Substance Abuse and Mental Health Services Administration, SAMHSA. She also has a joint appointment as a professor of psychiatry at the Johns Hopkins University. Dr. Jones is a global expert in neonatal abstinence syndrome and opioid-related disorders. She has written more than 250, that's a lot, people, 250 peer-reviewed publications, 2 books, and 17 courses on topics of substance use disorder treatment. She has co-authored multiple national and international guidelines on the topic of caring for pregnant and postpartum people with substance use disorders, including guidelines published by the World Health Organization and SAMHSA. Dr. Jones consults for the United Nations and the WHO and is a member of the NIH HEAL Multidisciplinary Working Group and the Advisory Committee on Research on Women's Health. We're very fortunate to have such a renowned national and international expert to give the first lecture of our Working for Equity series. Please join me in welcoming Dr. Jones.
Aw, thank you so much, Dr. Ah, for this wonderful opportunity. When you asked me, I was so excited, and to know that I'm the first one to set the stage is just humbling. And so, thank you all for spending your time with me this evening. I have a couple of videos that I'm gonna show, and I hope that this leads to a larger conversation. With the time that I have, we have 3 learning objectives to accomplish this evening. First, we're gonna take a look at the 5 key SAMHSA recommendations that came out of the guidance document with how to care for pregnant individuals that have opioid use disorder during the pregnant and postpartum period, as well as for their children. These are dyadic guidelines. That space in between the child and the birthing parent is so important. We'll also be comparing and contrasting the benefits and the drawbacks to looking at different medications to treat opioid use disorder and look at why detoxification isn't necessarily the right approach. And it's actually not recommended by any international or national guidance publication. And finally, we're going to do a call to action. What are those things that you can do right here today and from this day forward to help improve the outcomes and the way that you interact with patients that are pregnant and postpartum that also have substance use disorders? I like to start with this little slide here that just sets the context, and I want to make sure that we are continuing to dispel those myths that using buprenorphine or methadone during pregnancy is somehow against the FDA labeling. It is not off-label. It is solidly within the label. And if you read the product insert, you will see that there is information about pregnancy as well as lactation. So when you provide these medications, these are life-saving medications and can be very beneficial to birthing person and fetus. I'm going to also center this talk in living experience and living wisdom. So if you'll bear with me just a moment, I'm going to stop sharing my screen and share a brief video. And I love doing this because oftentimes I have the honor and joy of having patients with me when I'm giving presentations. And while I couldn't have an actual patient with me tonight, I did the best thing to have a video of one. And so let me see if I can share my screen again, and we will be able to see that video. Here we go. All right, I see the video. Let me go back to my big screen and see if I can share it. Here we go. And so this is Chelsea, and she is a proud woman in recovery and is going to share with you her thoughts. Thank you so much for being with us today. And what would you like to share to help providers best understand how to provide compassionate, responsive care to pregnant and parenting women with children who have substance use problems?
So I'm Chelsea. I am a person in long-term recovery. For me, that means I have not used drugs or alcohol since November 24th of 2022. What kind of pushed me into seeking help was finding out I was pregnant and not being able to stop using. And there was that innate fear of getting help when you're pregnant because your first thought is losing your child. And you want to try to do what's best for yourself and your child, which is getting help. So that was one of my biggest fears and biggest barriers, I think. And when I found Horizons, I remember going to their outpatient clinic for like my first kind of prenatal checkup with their provider there. And from the moment that I walked in the door, they just made me feel so welcome and unjudged. And that started at the reception from like that first person that I saw there. And she just made me feel just very welcome, very sweet. And then the nurse that checked me in, like, I just remember how kind she was. And she even told me a little bit about herself and her story and her experiences. And that just really put me at ease. And then I think I felt like there was just kind of a wraparound care that was provided at the program that I was at, which was, I feel like, what made the biggest difference in me staying and leaving and, you know, getting into recovery. And I think if I had faced people who were more judgmental of the things that I had done while pregnant, you know, like when telling my story in the beginning, it was I overdosed twice while pregnant, and I was using up until I was 5 months. So I was visibly pregnant, like very pregnant. And there was instances where I was seeking help in other ways at other doctors and, you know, the emergency room, and just the looks and the vibes you would kind of get from different doctors is so like it makes a difference in how I felt about myself as a person and as a pregnant person trying to get help. And at first that even pushed me further away from wanting to seek further help because I felt so judged when telling doctors, you know, yeah, I've overdosed pregnant, you know, twice and all these things that I had done. So I think just having that compassion and that empathy and that understanding when you're providing care to women and women with children, women who are pregnant, trying to find recovery and trying to get the help that they need, it can make a lasting impression.
Thank All right, so you could hear from Chelsea how incredibly important it is to have empathy, to be able to truly listen with our eyes, our ears, and our hearts. And I just think that I cannot stress enough how important that is. So thanks to Chelsea for sharing that. I want to set the stage, continue to set the stage, and to remind us that more than 48 million Americans have a substance use disorder. I am sure that you have all seen the incredible and overwhelmingly staggering statistics around the numbers of people who are dying every single day due to the poisoning of our drug supply. It does look like from our national data, we are getting a somewhat we've kind of plateaued a bit, but the numbers are still incredibly unacceptably high. And so I just wanted to put this slide up here to remind us that when we look at actual fatal overdoses, that is truly the tip of the iceberg, because we know for every one person who actually dies due to our poison drug supply, there are at least 30 that are going to the emergency department and being revived and saved. And we can't have a conversation around substance use disorders and overdoses without also talking about the pain that our population is in and the social drivers of health. It's harder more than ever to try and find safe and affordable housing. We have a myriad of behavioral health issues, trauma, violence, medical complications, all compounded by additional grief and loss through the COVID pandemic, through our overdose crisis that we have. And while the estimate of the financial burden you can see here on this slide, it is just absolutely, I think, not able to be calculated when we talk about all of the different ways that people have been harmed. And so that also means that people who are pregnant are not immune or in some way safe from a poisoned drug supply or safe from overdose or violence or victimization. And I put this slide up just to remind us that while a tremendous amount of attention is rightfully around the fentanyl and carfentanil and xylazine and nitazenes and all of those other things, not to mention methamphetamine, when we look at our national data by self-report, and I do emphasize self-report, we see that still the most common type of substance being reported by pregnant individuals are tobacco products and alcohol. And when illicit substances are reported, illicit is, a broad generalization, we see that most often it is cannabis that is being reported. Opioids and cocaine tend to be much less reported. So we have a tremendous amount of attention on opioids where it needs to be, but also we need to also remember we need to also treat and ask about alcohol and tobacco products. The other thing that I think is important when we talk about substance use disorders during pregnancy, which can engender a lot of feelings and emotions from people, is that we want to ground ourselves in reminding ourselves what is a substance use disorder. And I really think that a substance use disorder starts in the pediatric years. When we talk to people that come into Horizons, for example, we know that on average they start using at around 14 years of age. When we look at national data, 40% of patients report when coming into treatment as adults that they started initiating substance use under the age of 14. And so we have an opportunity early on to look at risk factors and to have early intervention so that we can have a better trajectory for people. And when we get to the point of having a substance use disorder, what does that mean? It means for many people that they have violated many promises that they've made to themselves and to others. If you can look at the purple, the blue, and the red, those are all behaviors that we see. The tolerance and the withdrawal are sort of the only two kind of physiological signs that we have. Tolerance meaning the first time you take a drug, you get an effect. The next time you take it, you don't get the same effect. You have to take more drug. And the withdrawal is that opposite of the drug that can make the opposite feeling that the drug gives you if you don't have it, which can be awful. It can make you feel like you want to die. And many of the patients that we serve actually say, I don't feel high when I'm taking these drugs anymore. I just don't want to feel so sick when I don't have it. And when we look at the other 9 signs that are behavior, we can see that these are very frustrating things, frustrating for providers, right? If people aren't showing up for their appointments because they're missing their obligations, because they were under the influence of drugs. They have personal problems. They're getting in fights with people, maybe being thrown out of the house for their substance use. The craving that, you wake up in the morning and you promise yourself, I'm never going to use again. And by noon, you've told yourself that 10,000 times and you just give up because you've got decision fatigue. And then we hear the patients that say, I'm just going to have one, right? And I end up having 10. And so when I think about an active substance use disorder, we think about all the behaviors that go with it. And oftentimes, what happens in our treatment system is that we actually reject people for actually expressing the signs of the illness that they have. And so I invite you tonight, as you're thinking about equity, to think about how we can do a better job of engaging our patients and coming up with tools to manage those behaviors so that they are less frustrating for our team and for ourselves, and that we can have better outcomes. The other thing I think about too when we're talking about substance use disorders is it really comes down to dopamine, right? We need food to survive, we need water to survive, oxygen, of course, but we also need dopamine. Dopamine is motivation. It's that thing that gets us up in the morning. It's our drive for motivated behaviors. And for people that aren't in active substance use or don't have an active substance use disorder, we know that our average day, kind of like today when you're listening to a webinar after 6 p.m., you've probably got about, I hope, at least 50 nanograms per deciliter of dopamine in your brain. If you've had an awesome day, you've won the lottery, everything's going your way, you might have 100 nanograms per deciliter in your brain. And in fact, your favorite food is 94 nanograms per deciliter. But when somebody takes drugs, particularly for the first time, it overwhelms our dopamine system. And you can have up to 1,000, over 1,000 nanograms per deciliter of dopamine in your brain. But that's usually only the first or second time. What happens with repeated exposure to the drug is that our dopamine becomes less and less accessible to us. And so for the patients that go to Horizons, what we often see is perhaps they have about 10 nanograms per deciliter of dopamine. And when you have low dopamine, it has tricked your brain into thinking that it needs that drug to survive. And that creates that craving. It puts your brain into survival mode, and that leads to that primal action where you will violate any promise or do anything to get that drug just to not feel so sick or just to feel normal. And so, what might keep our patients from seeking care? You heard it from Chelsea: fear, right? Fear of judgment, fear of their child being taken away because they're going to be reported to Child Protective Services if they're found to be using a substance or have a substance use disorder at pregnancy, fear of not wanting to be away from their children or their partner. So often, every day, our patients have to make a gut-wrenching decision of, do I parent and stay unwell, or do I go to a residential treatment program where I can't have my children and try and get well, but what's going to happen to them, right? And then, of course, the incredible fears about stigma and privacy. And I can tell you from data from 1971 all the way up to 2024, fear is the major driving factor that prevents patients from seeking care. And why is that so important? We know that if we can get pregnant patients into prenatal care, even if they don't stop using substances, we've got data from the 70s to the 2000s to show we can improve birth outcomes if they just can access that prenatal care. And we also know that untreated substance use disorder among either parent, any caregiver, sets the occasion for a dysfunctioning home environment that can create long-term detrimental effects for the children. So if we want to get and have brighter futures for our children, we have to work with the birthing parent, with the family unit, to be able to break the cycle of abuse or challenges that they have to help the next generation. So, what does ACOG recommend in terms of how do we identify pregnant individuals that might be using substances? Universal screening. That does not mean urine drug testing. That means a verbal screen to ask, it's self report, starting with prenatal care to normalize that, asking, how much are you smoking? How much alcohol are you drinking? What types of drugs are you using? It's very different questions from, you don't smoke, do you? Right? That will definitely get you a no answer. And once we have the answer, the yes answer, I am, you drinking some alcohol, smoking cigarettes, smoking cannabis, then we need to respond with a non-judgmental person first response. Let's have a conversation. Is it okay if we could talk about that and the role that those substances are playing in your life? And making sure that we have those other pieces in place to allow for a multidisciplinary follow-up. I love to have the patient voice as part of any talk that I give. And so, having asked patients in the not too distant past what their ideas are for how we can do a better job as providers for screening, here are the 9 answers that they told us. For sake of time, I'm not going to read them all, but I love number 3. Specifically ask for our consent to ask the questions. And if we refuse, don't assume the worst of us. Number 7, give us an option to complete questions by interview or by electronic questionnaire. I feel better answering questions online. Makes me feel more confidential and less stigmatized. So they have wonderful wisdom about ways that we can tweak our practices to get more honest patient responses so that we can help them. I also want to draw your attention to the fact that when we have pregnant individuals that are using substances, it doesn't mean that they all have a substance use disorder. That slide that had the 4 different colors on it and the 11 signs of a substance use disorder means that we have now the continuum of a mild to moderate to severe substance use disorder. And then we have no use, right? So, the beautiful thing about the American Society for Addiction Medicine is that there are different levels of care. And I know Delaware has worked really hard on having a good continuum of care so that patients truly have a choice of where they can go that can best match the severity of their substance use disorder. And when we talk about opioid use disorder, we need to talk about medications because they are the most effective way of treating and managing opioid use disorder. And so, just to level set, we have a number of different types of medications. We have our methadone, which is our full mu opioid agonist, which basically means we have all of our opioid receptors. When the methadone comes in, it locks onto the receptor and fully turns it on. That means the more drug you get, the more effect you get. And that is why it is possible to overdose from this drug if it's given too fast, too much. Buprenorphine, which was approved in 2002, is a partial mu opioid agonist. And the good thing about buprenorphine, we have these opioid receptors. The medication comes on, locks on the receptor, but only turns the receptor on about halfway. It's like a light, a dimmer switch, only halfway up. The nice thing about that is it makes it really hard, not impossible, but really, really hard to overdose on buprenorphine alone. The buprenorphine overdoses that we see are often when the buprenorphine has been given by injection and it's combined with benzodiazepines or other CNS depressants. And then we have naltrexone or naloxone, right, which is a full mu opioid antagonist. Medication comes in, locks on the receptor, but doesn't turn the receptor on. So pharmacologically, we can block those effects of the illicit types of opioids that we're trying to stop without having any type of psychoactive effect, which is great in practice in pharmacology, doesn't work so well in with patients because they like to feel something, right? And sometimes the thing that they feel might be nausea or headache or kind of low-level withdrawal symptoms. So that's why naltrexone is often given as an injectable form rather than an oral form to increase the adherence to the medication. When we talk about medication and opioid use disorder and pregnancy, the only medication that we had for like 50 years was methadone. And here you can see sort of a timeline of methadone literature. I always love to call out Dr. Melissa Freeman because she is one of our unsung sheroes of addiction medicine. And she was at in the Bronx, and she was among the first physicians to ever prescribe methadone to pregnant patients. And so I think we need to honor her for her pioneering work. And as we saw with methadone, and I'm sure many of you are familiar with, methadone being a full mu opioid agonist, when we no longer have methadone, like a baby is abruptly discontinued from the methadone exposure, when we cut that umbilical cord, we run the risk of having a withdrawal, right? We know that withdrawal, we know what to expect. We have good tools to treat it. We have good ways of assessing it. And it's still there, right? And if you've ever seen a baby that has neonatal abstinence syndrome that's not treated, it can look pretty disturbing and uncomfortable and concerning. So there are a couple of things I want you to know about neonatal abstinence syndrome. One, babies cannot be born addicted. If you remember that slide with the 11 signs of a substance use disorder, having a substance use disorder means continuing to use the substance in spite of negative adverse consequences. Babies don't have enough life experience to have adverse consequences, and certainly they're not continuing to use the substance. So they cannot be born addicted. They can be born in withdrawal from opiates. They can be born physically dependent to opioids, but not addicted. Also, too, I want to differentiate neonatal abstinence syndrome from fetal alcohol syndrome. We have good data that tells us about the long-term deleterious effects of prenatal exposure to alcohol in high quantities, particularly with older pregnant and parenting individuals. Neonatal abstinence syndrome, we do not have that same data, and I'm going to show you a little more data about that. We know that it is treatable, and we also know that if we can get birthing person and baby off on a good solid attachment, that increases the resilience factors and can minimize the withdrawal. And so just to define neonatal abstinence syndrome, it's a constellation of signs and symptoms that affect the central nervous system. So it affects the autonomic nervous system. We can get babies can have difficulty sucking and swallowing or some diarrhea, and on occasion, some signs of respiratory distress. So why were we interested in buprenorphine, right? Buprenorphine is that partial mu opioid agonist. And so back in it feels like the ancient days now, in the early 2000s, we gave buprenorphine to pregnant women under experimental conditions because we thought, when we saw adults that were abruptly discontinued from their buprenorphine, they had a milder withdrawal than they did from being abruptly discontinued with methadone. So we thought, if that's true for adults, maybe it would be true for babies too. So we did all of these open label studies, which means that mom and provider and nurse who was evaluating NAS for the baby all knew what mom was taking. And in the early days, we saw no neonatal abstinence syndrome, and we thought we had found the holy grail and we were going to make everything better. Obviously, today, you know how that story ends. There certainly is a risk for neonatal abstinence syndrome with prenatal buprenorphine exposure. However, it is still continues to this day in our literature to be less severe than compared to methadone. That doesn't mean we shouldn't use methadone. Both medications are good, and I'll talk about that. So we, back in, again, those early 2000s, we needed to do a study comparing methadone, our standard of care, to buprenorphine, which looked to be better under non-blinded conditions. And so we thought about, how do we do this study? Well, one very important thing is that we couldn't use a placebo because of this study that had been done by Johan Keiko, where he actually showed he randomized patients to nothing, to placebo versus buprenorphine. There were 4 patients that actually died during this study, and it was stopped. So this was very conclusive evidence that buprenorphine saved lives and prevented death. So we did this very fancy study that was a double-blind randomized study, which meant that patients nor providers nor nurses who were evaluating the baby for NAS knew what the patient was taking. And our main outcome was looking at the relative safety and efficacy of methadone versus buprenorphine and also neonatal abstinence syndrome. And what we found was that when we just looked at the proportions of babies that were prenatally exposed to methadone or buprenorphine, there weren't any differences. But when we looked at if you had to be treated for your neonatal abstinence syndrome, that's where we saw the differences. And that's where we saw that if you were a prenatally exposed buprenorphine baby, you required significantly less medication to treat your neonatal abstinence syndrome, which meant you got out of the hospital faster. The other thing that's really important about this study is that we looked at maternal outcomes. And many of the maternal outcomes and other outcomes, as you can see here, were not different. So what this study did is it gave us the very first relative safety and efficacy study for methadone as well as for buprenorphine, so that we could expand and have 2 medications to treat opioid use disorder during pregnancy rather than just one. We have a whole host of other questions that we asked using this multi-center trial data. So if you're interested in fetal effects or breastfeeding or predictors of NAS, I encourage you to take a look at this. One big question that I'm going to focus on was, what about the children? Because knowing what the potential long-term outcomes are is really important when we're talking about pregnancy. And so we followed 96 of the children up to 36 months. We looked at the data every which way we could. We compared the children's outcomes on physical, cognitive, emotional development compared to normative samples. And we didn't find any differences either between the groups or compared to the normative samples. And so what was reassuring about that data is that it didn't look like methadone or buprenorphine looked worse than either one, and didn't necessarily look worse than children that were developing without that sort of exposure and looking at population norms. Fast forward to the 2014 to up to 2020, there have been a lot of kind of meta-analyses that have been looked at, expert reviews. Do we see differences in children prenatally exposed to opiates? A lot of this literature is focused on methadone. By and large, no, we don't see differences. And when we do, I'll point you to the Nelson study in 2020. When they really looked at this data, prenatal exposure to tobacco was one of the major driving factors. And if there is one piece of advice that I would give, please, please help your patients to look at the role that tobacco is playing in their life and where they can reduce, because we have excellent and robust data to show that the more a patient is smoking during pregnancy, the bigger the chance, the worse NAS is going to be. And if we can cut down, you get the reverse. The other thing I will say is when you look at this long-term literature, I would encourage you to look at it with a critical eye. Because we had, for example, this study looking at long-term outcomes in high school, for example, out of Australia. And when we looked at for example, a seventh grade outcome, how much of that reading score, school performance was really explained by a neonatal abstinent exposure, and that was only 3%. That means 97% is something else that's going on that hasn't necessarily been defined. So we know that prenatal exposure can be a risk factor, but we need to look at it in the context of all the other aspects of the person's life. So what do our SAMHSA clinical guidance recommendations tell us? First, we want to avoid using medication-assisted withdrawal during pregnancy. Second, both methadone and buprenorphine are safe and effective medications to treat opioid use disorder during pregnancy. Third, we don't want to necessarily transition a patient from one medication to the other just because of a potential, protective factor around neonatal abstinence syndrome. We need to be talking to the patients, understanding what medication they feel most comfortable with, what's been their past experience, and what is their choice, right? Preference, values, choice, and access to the medications are really important. Breastfeeding also is very much recommended for patients that are receiving methadone or buprenorphine. And finally, the other one was that neonatal abstinence syndrome shouldn't be treated with diluted tincture of opium. I want to draw your attention to the guidance document. It's got 16 fact sheets. They're very user-friendly for both patients as well as providers. And there have also been some updates, and there are 4 new fact sheets around how to work with Child Protective Services with patients that have substance use disorder during pregnancy. So let me just touch and drill down just a bit more on why we don't recommend detoxification. In the old literature, what the opinion was in tip number 2 from SAMHSA was that it would increase the risk of fetal demise, like premature labor or premature miscarriage or things like that. Through systematic reviews, we were able to show, no, that's not really the case. What the issue is that detoxification doesn't work very well for non-pregnant patients. And we have no reason to think it would work better for pregnant patients. It's just a mismatch. It's an acute care intervention for a long-term chronic illness. And we also see, on average, 80% of patients that complete detoxification have a return to drug use by 1 month. So we need to do something different. That's not working very well. Other things that SAMHSA have done that I want to highlight: in May of 23, they did an updated guidance briefing that's about 12 pages. And so 2 points that that I want to highlight for you here from that document is that they highlighted increased or split dosing may be required for patients during pregnancy receiving either methadone or buprenorphine. So we need to dose to the optimal functioning of our patient. And also, too, it had a lens of equity that we want to make sure that we're giving those supports that are culturally and linguistically effective in their care. So why do we continue to worry about using medications to treat an opioid use disorder? We want to help our patients get back to that feeling of normalcy. So not that recycling of high and withdrawal, because that's not good for the pregnant person. It's not good for the embryo or the fetus. We want to get to that feeling of normal. Unfortunately, while we talk a lot about medication to treat opioid use disorder, if you look at this map, and this just came from the 16th of July, you can still see we have wide swaths of deserts of no access to medication to treat opioid use disorder. And this is looking at places that might have two or more. I will say Delaware is doing really well, as you can see from the map. So keep up the great work, and hopefully all can be a model for the rest of the country. As we look at even who gets access to medication to treat opioid use disorders during pregnancy, we really see stark racial discrimination. There is massive structural inequities. And Davida Schiff's data really point this out. These are data from Massachusetts. And what we saw was that, first of all, we saw that overdose can be prevented with patients that are receiving pharmacotherapy compared to those that are not receiving pharmacotherapy. Which she also pointed out was that patients who are Black and brown are more likely to receive methadone than our white counterparts. We also have other data, as you can see here on this slide, that just overall, not even during pregnancy, but overall, we've got stark racial discrimination with the capacity of methadone being higher in counties where Black and Hispanic individuals lived. Buprenorphine was higher in counties where white residents lived. And so, and also too, just to highlight that our non-Hispanic Black women and Hispanic women are less likely to receive any medication compared to non-Hispanic white women during pregnancy, and non-white women were less likely than white women to continue to receive those medications postpartum. So we need to be asking our questions of our treatment providers of opioid use disorder treatment. Who are you seeing? Who do you need to outreach to? What do your outcomes look like? There is no reason why we can't have parity and equity in this realm of healthcare. I want to give a shout out to SAMHSA for and Dr. Olson for giving us this wonderful letter in 22 to reaffirm and emphasize and highlight the fact that we need to be giving methadone and buprenorphine in a split dose condition. We see that we get better outcomes, and we actually have a systematic review that is highlighting and reinforcing that it is okay to give them this dose in the morning and in the evening, and we get better functioning. If you are working with patients who are receiving methadone, I encourage you to have conversations with them, even if you are not the prescriber. Having a release of information to be able to talk to the prescriber is super important. And as you're working with patients, ask them, how is the medication working for you? Ask if you're experiencing withdrawal. What about over-sedation? So often we're worried about under medication that we forget to look at the reverse, and particularly in the postpartum period. We need to be looking we've got sleep-deprived patients. How is this medication working for them? Do we need to split the dose so that they're not in withdrawal in 1 minute and over-sedated the next? We know that in the age of fentanyl, the way that we are dosing both methadone and buprenorphine is wildly changed. So I draw your attention to the PCSS that is got some really nice practice guidelines that are just as relevant for pregnant individuals as they are for non-pregnant individuals. So here are some ideas, as well as not forgetting, which is remembering to include all of those symptomatic medications that can be really helpful to make it much more comfortable for patients to initiate on their medication. And then when we think about buprenorphine, oftentimes if I'm hearing that the medication isn't working for patients, we want to find out why, right? Sometimes we've had inadvertent initiations onto buprenorphine and it precipitates a withdrawal. But if we can earn the trust of our patients, then they can feel more free to tell us how long it's been since the last time that they used their opiate. So we can start to bridge them. We can start to initiate low doses while the opioid gets out of their system. We want to talk about safety planning. We want to make sure that we're co-prescribing naloxone, allowing naloxone or facilitating naloxone to be given to family members. And also, too, the biggest misconception that I see with buprenorphine is that patients put it under their tongue, they might swallow it, they might only give it 30 seconds to dissolve. It needs to take ideally several minutes in their mouth without swallowing for it to dissolve. And ideally, they want to avoid smoking and drinking 30 minutes before as well as 30 minutes after. That way, they get the maximal effect of their medication. We also get questions about, is it okay to use the combination product of buprenorphine and naloxone during pregnancy? The answer is yes. We have systematic reviews and meta-analyses to support that, as well as Canadian and US guidelines. In terms of naltrexone, we are learning a lot more about that during pregnancy. We have a few papers that are out there, but I would say that still the risk benefit is still a bit unknown. If you have patients that are receiving that naltrexone, they're having a good response to it, I would have a good conversation documenting the risks and benefits, the shared decision making that you're having with your patient, and then decide together if that's the best medication for them to stay on. I will say we've seen patients that have been removed from their naltrexone and become very destabilized. So if it was with our patients at Horizons, by and large, we work with them to stay on their naltrexone. Other things to think about is pain control during labor and delivery. We need to believe our patients when they tell us that they are in pain. We know that the buprenorphine and the methadone alone is not sufficient to be able to treat their pain postpartum, or certainly not during labor and delivery. We want to obviously avoid partial agonist-antagonist medications when we have patients that are receiving methadone or buprenorphine. And so we can use full opioid agonists to get control over that pain. And being in pain, we know that people that have opioid use disorder, one, they're more sensitive to pain, they have a lower pain threshold. And two, that can be a trigger for a return to use and destabilization. So we need to make sure that our patients are comfortable and functional. Breastfeeding and chest feeding. So we recommend that. I draw your attention to the latest ABM protocols. There's a QR code for you to take a look. They've got some really wonderful recommendations in how to talk to patients. We want to be supportive to our patients. Once our patients deliver, there is so much shame and guilt and fear that comes up. So taking the moment to tell them what they're doing well, calling out the positive, can make all the difference in the world. Again, want to make sure that we are co-prescribing naloxone for our patients. We also want to talk and test for syphilis. We know that that is absolutely on the rise. That is something we've got to be making sure that our patients are aware of and have ways to protect themselves and ways to get tested and treated if they need. We want to encourage skin-to-skin bonding. Our patients sometimes need to be shown how to do this, how to feel comfortable doing this. And the less judgment that we can give them, the better off they will be. And to also engage partners or family members where appropriate to help them understand what the birthing parent is going through, to be a support, to be a help, and to also assess or at least screen for postpartum depression and other mood disorders, because we know that that is a big risk for our people, that our patients that
I think Dr. Jones is frozen. Dr. All, are you still with us?
I'm here.
Okay.
It looks like Dr. Jones dropped off.
Okay, she did earlier advise that she was having some storms, and if she did drop off, she would be right back. She'll go do a quick reboot.
Okay. Thank you, Lynn.
Sure thing. While we are waiting for Dr. Jones, I will share that we do have the next event is scheduled. And so please, can you see my screen share, Dr. All?
Yes.
I just want to make sure, if everyone just save the date, Thursday, August 15th at 6 p.m. This will be a virtual session as well.
Oh, and I think Angie put something in the chat about CMEs or continuing education credit.
Excellent. Thank you.
I'm so sorry. I'm back.
Hello, Dr. Jones.
Hello, I'm so sorry. The internet totally conked out on me there. It was a storm. So
No worries.
if you want to let me share my screen, I'd be happy to
Yeah.
go back to what I was saying. All right. So I don't exactly know when it conked out, but I was talking about fathers and the role that they had, the important potential role that they have for helping birthing people with lack of sleep, and also talking about realistic expectations for sex after pregnancy. So other things that are important to think about too is that we shouldn't be thinking about medication alone, that we want to be thinking about wraparound services. And as you can see on this slide, we have a number of behavioral interventions that can be really helpful for addressing alcohol, cannabis, and stimulant use disorders. And I'm going to call out contingency management. That is absolutely, bar none, the most effective treatment that we have for stimulant use disorder. We just need some help and support from all of our policymakers to help get that implemented more widely. In terms of NAS, the other really important thing to think about is that we know that we can reduce the severity of neonatal abstinence syndrome when we have standardized protocols that are in our hospital setting, when we can keep babies out of the NICU just because they have neonatal abstinence syndrome. Certainly, if they have other things that would require NICU admission, they need to be there. But we don't need to be putting babies into the NICU just because of neonatal abstinence syndrome. And breastfeeding, as well as skin to skin, can reduce the need for medication. And we have a whole game changer with the Eat, Sleep, and Console paradigm. And these are data just to show how Eat, Sleep, and Console was implemented in the UNC hospital. And we had our average length of stay here. We can see our average length of stay here was an average of 10 days. And then we were able to reduce it to 4.9 days when we implemented Eat, Sleep, and Console, which is a much more responsive and shared decision-making approach to initiation of medication. They also changed the medication from we initiate and maintain and wean to just giving medication PRN, and that worked really well. Birthing parents, moms, and babies liked that a lot better, as did our nursing team and physicians. So what can you do? With the last couple of minutes I have, what can you do? You can think about your language that you use, and I want to invite you to think about how we talk about urine drug testing. So often I hear providers, clinicians, as well as our patients say, "Oh, I'm clean today," or "Oh, she popped dirty. She popped a dirty urine." That does not honor or recognize substance use disorders as the medical illness that it is. It can also be stigmatizing and punitive. And so I invite us to think about changing our language to a more medicalized language of being positive for a substance or being negative for a substance. What else can you do? You can be honest and transparent with your patients. You can ask permission before you ask those why, what, and how questions. You can look for stories of success and tell those stories of success, just like with Chelsea, who is our proud woman in recovery. Recovery happens every day. So many people sustain their recovery. Making sure that we're pointing out their strengths, anything that you see. And I remember a physician that we had, a pediatrician, who had a mom come back to her many, many years later. And the mom actually told her, you know, when you saw me one day, you said that I was the best mom for my baby. And I have kept that with me and remembered it for many, many years. So never doubt the power of your words that can change someone's life. And let's advocate for those compassionate care models so that we're doing the best that we can to help keep birthing person and baby safe, and also not putting them in a fishbowl where they're scrutinized and penalized. And also remember that Narcan can be used for all ages and stages, even with babies. I know I'm wanted to give a few minutes for questions, so I wanted to just highlight voices of experience, and I'm going to end with a video. But make sure this is from our patients. Make sure that everyone who is asking about drug use also knows what to tell people about where to get help. Don't tell us, I don't know how to help you or what to tell you. And so please, if you're screening, make sure that you have referrals and ways for patients to be helped. And with that, I'm going to share one more video. And this is Rose Horton, who does an amazing job. I aspire to be Rose Horton in how she talks to patients. Here we go.
We can't hear.
Oh, you can't hear? Okay, hang on just a sec. Sorry. Let me stop sharing. I wonder what I need to do differently. Let's see. Could you see it?
Yes, we could see it.
Okay, great. All right, let me try again. I think when I got disconnected, I had to, oh, what did it do? Let's see. Share optimized computer sound, share stereo. Okay, here we go.
Play to show
Can you hear it
you
now?
how we can engage with
Yes.
our patients to really decrease their anxiety and to help ensure that the experience that they have with us at our hospital, our organization, is respectful and it's courteous. I'm sure many of you do this anyway, but here goes. So we're going to do a little role play. Hi, my name is Rose and I'm going to be your nurse today. I know we met unofficially during bedside shift report. Kathy, your night shift nurse, told me that you go by Amanda. Is that correct? Great. Hi, Amanda. I just want to take a few minutes to tell you a little bit about me. And also I want to share with you what I commit to in the time that I'm going to be caring for you. Is that okay? Great. Well, I have been a nurse for 20 years and I've been taking care of women in the birthing community for that long. So I feel very comfortable and very confident in my ability to provide respectful, courteous maternity care. To that end, let me share with you a couple of things that I am committed to. Number one, I'm committed to treating you with dignity and respect. What does that look like? Well, before I enter your room, I'm going to knock on the door first, right? I'm going to knock. I'm going to wait to hear you tell me to come in, and I'm going to come in. I'm going to make sure that I pull the curtains behind me so that I protect your privacy. I will always speak to you in a professional manner with compassion and with kindness. I'm also committed to providing evidence-based care. What does that mean? That means that the care that I provide is based on literature, it's based on data, and it's based on science. We don't make any haphazard decisions here, no opinions. We really provide care in a scientific manner. I'm committed to listening and believing you. Listening with empathy is super important to me. So if you tell me that you're in pain, I believe you. If you tell me that you're afraid, you feel overwhelmed, you feel exhausted, whatever you tell me, I believe you. I also commit to shared decision-making. I am here to amplify your voice. This is your birth, your experience. I want to amplify your voice. So what's important to you, It's important to me that it bubbles to the surface, right? That it becomes a priority. And last but definitely not least, I am committed to being your advocate. You have done an amazing job for 9 months to carry this baby to term. So you know that your body's capable, you're strong, and you are enough. You don't have to worry and be filled with anxiety or stress because you think you're going to have to fight for everything, fight to be listened to be heard, and to have the birth that you want. You don't have to do that. All I want you to do is take a deep breath, relax, allow your body to engage in labor because your body's ready for this. You're ready for it. I got you. I see you. I hear you, and I am your person. So all you need to do is just focus on you, focus on listening to your body, focus on this experience. Together, I'm sure we'll have the birth experience that you have been planning for. That's the end of our role play. Respect.
All right. And with that, I'm going to stop and I'm delighted to answer questions. Thank you so much. And I apologize for the internet bubble.
Thank you so much, Dr. Jones, for that excellent lecture. Questions, raise your hand, unmute yourself and ask questions. And if no one has one just yet, I do have one. Dr. Jones, can you explain what you mean by contingency management as it applies to substance use disorder?
Sure. Thank you so much for that question. So contingency management has been around since the 1980s. It was some of the first studies were done at the University of Vermont with Steve Higgins and his colleagues. And so, and it's not intuitive in the sense that people come in and they provide a urine, and that urine is tested for the drug. In this case, it was cocaine. And if the urine did not have cocaine metabolites in it, patients received a monetary reward. And so it would start out at $2.50. And then the next urine, so they would do like a Monday, Wednesday, Friday. So it was $2.50 for the first urine. The second urine was $3.50, so on and so forth. So what happened was that the longer you had demonstrated abstinence from cocaine use, the more money you could earn. And this is like, there have been meta-analyses that have been done. There's been systematic reviews. It's been replicated all over the place. California actually has adopted it. Their Medicaid is actually paying for it. The problem with the way it's being rolled out is that the monetary reward isn't enough to change behavior. And there's a limit on how much is allowed. And so, we and also too, there's the sort of a lot of people have, oh, why are we paying people to do something that they should be doing anyway, right? Doesn't this like in some way diminish their internal desire for change? And when you stop the contingency, you do see there is certainly some return to cocaine use, but not to the extent, like overall, when we look at the data, it's not to the extent that it started out with baseline. So, which would be the same as we're working with medications, right? You withdraw a medication, it doesn't, you get people that have a return to drug use. So here is this very powerful, very effective, and efficacious intervention, but it's not really politically popular for, all these reasons.
Thank you. Other questions?
Yes. Are these
Oh, Erin, I missed what you said.
based on harm reduction or stopping of are any of these models based on harm reduction or getting like just medicating so their moms are not using as much?
Erin, so I let me make sure you were cutting in and out, so I had a little bit of difficulty
I'm sorry.
hearing you. That's okay. But I think what you asked, and you correct me if I'm wrong, I think what you asked is sort of like to what extent is harm reduction part of part of the model, right? So
Yes.
yeah. So for example, let's say that, well, I can speak for Horizons. Let me speak for the Horizons model. So when we have patients that come to our prenatal care clinic, our patients come, they're actively using, and they might continue to actively use throughout the whole duration of their pregnancy. We would not ever, quote unquote, kick anyone out or let anybody go unless they wanted to no longer see us. So we're very much in the idea of we will meet patients wherever they are, and give them the care that we can best give them and help give them the tools and resources to make their best decision. Does that help answer that question?
Yes. Yeah. And this has been a really helpful lesson for me. I work for WIC, so I've seen, well, now since we don't have clients in clinic, everything's over the phone. I would see moms, at all points, whether they're wanting to get clean or wanting to, still trying to decide what they want to do, or whether they're in active like recovery, or they've been sober for 10 years, but everyone's version of and definition of what they consider sober is so different. And you know what every clinic's version of what they consider sober is different as well, I know. And like what connections would be like, you can't use anything. And I know a lot of people that are completely don't use any sort of like medication, get very offended when people that use medication for maintenance meds are like, you're not clean, you're not sober, you're still just replacing one thing for another. And it's a very heated debate whether people are clean if they're on maintenance medication or if they're not.
So this is a conversation, Erin, that we're going to have to continue. We do thank Dr. Jones for her excellent presentation, but Erin, this is something here in Delaware, looking at health equity and just the substance use landscape. We will have to continue this conversation on an ongoing basis. But I have 7:03, and I want to be respectful of everyone's time. We do thank you very much, Dr. Jones. And I will hand it over to Lynn for any closing words before we hop off.
Oh, thank you both. Thank you, Dr. Jones. What an excellent presentation. If you have any additional questions, feel free to send them. You can email them to the Medical Society of Delaware, and we're happy to send those along to Dr. All and Dr. Jones. And I will once again, just very quickly, I will post the date for the next upcoming presentation on Thursday, October 15th, 2024. And again, for CME, Ansha did post in the chat box. So keep an eye on your email following this presentation. We thank you again, and have a great evening.
Thank you.
Thank you.
Bye-bye. Thank you.
Take care.